morning. أنا محمد الوادعي emergency resident third year في KKUH. على البركة التخرج يا شباب. Congrats. Welcome to hell. You will remember this 3 years from now or 4 years from now. طيب. I'm going to give you 2 talks, chest pain and headache. It's consecutive talks. Why did I choose these talks? I chose them for 3 reasons. Reason number 1, they are extremely common. Reason number 2, they can kill a patient. Reason number 3, I know maybe 20–30% of you guys gonna deal with these complaints almost on daily basis in the future. The rest, maybe not, but I'm 100% sure that you're gonna get a call from a friend or a family member or a neighbor asking you about these 2 complaints. So I don't want you to miss a patient. Bye. How do I approach any patient with a complaint? I have a thought process. It's 2 steps. At least this is my own. Step number 1 is these 2 questions. They come together. How does the patient look? What are the vital signs? If he looks ill, I don't care about the vitals. If he looks well, I move to the next question, which is the vital signs. They call them vitals for a reason. So, what are the vitals? If anything is abnormal or he looks ill, this patient needs to be seen now. This gives you time. When you're on call and somebody called you, and the nurse said, he looks ill, or the vitals are abnormal, you leave whatever you have in your hands and you go see the patient. If he is looking well and vitally stable, you have a few time to finish your things and go back to the. So step 1 is how does the patient look and what are the vitals. So then I move to the next step. Step 2 has 2 questions. Sometimes one comes before the other, but usually it comes like this. Should I intervene now? Second question, what are the life-threatening possibilities in this patient? Okay? When I look at chest pain, I don't care about musculoskeletal, I don't care about shoulder pain. I look at the life-threatening causes. So, should I intervene now? Interventions comes in different ways. Calling the senior is one intervention. Giving him oxygen is another intervention. Putting him in the lateral position is another different interventions. Ordering ECG, ordering chest X-ray, suctioning. All of these are simple interventions that could change the outcome of the patient. So, sometimes your interventions based on what are you thinking about as in terms of critical diagnoses. Okay? So this is the most important slide of the talk. Pay attention. This is the critical diagnoses of chest pain. 6 things. Whenever you have chest pain, you need to think about these. Acute coronary syndrome, the whole spectrum. We're talking about unstable angina, non-STEMI, STEMI, so the whole spectrum. Second is pulmonary embolism, then aortic dissection, then cardiac tamponade, then tension pneumothorax, and lastly is the cardiac tamponade. So, critical diagnoses of chest pain. 6 things you need to remember. Okay? This is the second most important slide. When you're in doubt, call for help. Okay? So, we'll go through some cases, covering the 6 cases. So, this is a 53-year-old male who was admitted under care of pulmonology, complaining of chest pain. You get called from the ward by the nurse, chest pain, heaviness in nature, radiating to the right arm, on and off, exertion-related, associated with vomiting, sweating for 30 minutes. He looks well, so this is my first question. Second, vitals, apart from high systolic, there is nothing there. So he vitally stable, he looks well, but it's a serious complaint with serious feature, right? So step 1, he almost needs to be seen now because of the serious complaint. So I'm thinking about acute coronary syndrome, right? It's a typical chest pain. This is what they've been teaching us med school. Textbook teaching, classical, is typical chest pain. So you order an ECG. This is the ECG. What do you see? There is no elevation. This is just a simple sinus tachycardia. There is no ST elevation. There is no signs of ACS in the ECG. So this tells you that ACS can be presented with normal ECG. So this is another message that I want you to go home with is ACS can be presented with normal ECG. So you need to do serial ECGs to pick it up. Maybe it's early, but you need to do serial ECG. So when should you be concerned, less concerned, more concerned, freaking out when you hear chest pain? The complaint itself by the history. The typical versus the atypical. Left-sided chest pain, radiating to the left arm, sweating, nausea, jaw involvement, right? So ideally, clinically, what we've been seeing, and it's been proven by scientific evidence, that these are not the huge amount of patients we see. There is a huge subset of patients we see with atypical, what they call it. I hate this word, but what they call the atypical, which is in a certain population we see. The diabetic, the elderly, and the female, right? So these three patients, they have tendency to present with angina equivalent symptoms, which is they don't have a chest pain. So you need to consider these three subset of patients when you see them. They don't come with chest pain. The typical versus the atypical is not always there. The typical, what I mean. So I like more is the more likely and the less likely. So this chest pain is more likely to be a cardiac origin. This is less likely. This gives me from the beginning that I am not eliminating the ACS from the differential. So it's less likely, but it's still, there is a possibility. So what do we mean by more likely, less likely? Symptom-wise. So retrosternal chest pain for a longer period, 3 to 5 minutes, that comes with exertion, there is sweating, there is nausea, vomiting. This is more likely, right? But I say, if I tell you this is a localized left lateral chest pain, I can point it with one finger. It's reproducible when you touch. It's increased by inspiration. It comes for seconds and goes. There is no associated symptoms. This is less likely, but you should still consider the possibility of ACS still there. So we said what we will do, call the senior, do ECG in the meantime. You can do 12 leads, 15 leads. It's going to take time if you're in the ward. Give him aspirin if he's not allergic. You can give 2 baby aspirin, 3, 4. It's all you can give. Or you can give 1 tab of 300. So you can order a chest X-ray. Give him oxygen, as we've been taught in med school, the MONA abbreviation. So you don't need to give oxygen to every ACS patient or suspected ACS unless he is hypoxic. It's proven that could be harmful. Okay, so don't give oxygen unless he is hypoxic. I would leave the pain and the analgesia and the nitrate for the senior. You can give nitrate unless it's contraindication, Izordil or what you call is azosorbide dinitrate. So what are the contraindications for nitrates? Hypotension. Less than what? Less than 90. Then? Right side in mind. Or suspected right side in mind. What else? Okay, erectile dysfunction medication, last 24 or 48 hours. They add aortic stenosis, anything that's preload dependent. Okay? So, remember, ACS can be presented with normal ECG, and ACS can present with angina equivalent symptoms. Okay? So, we move to the second case. This is a 35-year-old male post-gastric sleeve 5 days ago, complaining of sudden chest pain associated with dyspnea, right side chest pain. Exam, he's tachypneic. Blood pressure is okay, tachycardic. His respiratory rate is 28 and his oxygen sat is 87 room air. So when you look at him, he has right leg swelling. So how does he look? He looks well, L from the exam. He looks L, he's tachypneic, hypoxic, low-grade fever. So he needs to be seen now, right? So what are we working on? P, right? So what do you want to do? It will take time. So you want to increase the likelihood of your differential by doing, so simple things. D-dimer will take time. You ask for what? ECG and it will take, film call تسوي Doppler. It will never be done unless the radiologist مرة cooperative. So should I intervene now? We said yes, he's hypoxic, right? So what can we do? Give oxygen, right? So life-threatening possibility is PE. Consolidation, what shape? طيب كلمت السينيور وقال لك this is pneumonia, he has fever, he's just been operated والatelectasis lung, فgive him antibiotic tomorrow medicine will review. ايش رايكم؟ أيوه. So you escalate. You tell him this is high likelihood of having a PE, you escalate. You convince him, if not convinced, you can call the senior. So this is a critical diagnosis, you don't want to sleep on it. Sorry? He's hypoxic, he looks ill. You arrange for CTPA emergently. You can, giving heparin or not, depends on the surface you're working on. I would leave it for the surface concern. If he is high, if you consider him high risk. So, third case is a 57-year-old male, SLE hypertensive, admitted under care of rheumatology, chest pain, retrosternal tearing, radiating to the back, shoulders, nausea, sweating. He looks ill, diaphoretic. Blood pressure on the higher side, systolic is 180, diastolic 120, tachycardic, but his oxygen and saturation and respiratory is okay. So, first of all, does he look, what does he look? He looks ill, right? Okay. Vitally stable, other than the systolic blood pressure. So I need to see him now. So what I can do for him, should I intervene in the meantime? There's not much I can do other than requesting ECG, chest X-ray, calling for help. So what are the life-threatening possibilities in this case? Aortic dissection, right? MI is still a possibility, but my top differential is aortic dissection. Based on what? History, right? Risk factors, having hypertension, SLE, right? Other than that, tearing, the character of the pain. So aortic dissection is a possibility, ACS is still there. I should think about the other 6 differential, but I can rule them in or out by history, collective symptoms, history, ECG, the others. So this is the ECG. Do you expect to see anything for the aortic dissection? It can be normal. You can see some, if there is extension to the back, and you can see inferior MI. You can see some LVH pattern if he's uncontrolled hypertension. So they still could have a normal ECG. This is the X-ray. ايش رايكم؟ Wide mediastinum. صح? There is left pleural effusion. So there is 9 signs in chest X-ray with aortic dissection. The most specific one is wide mediastinum. They still could have a normal chest X-ray. So if you're suspecting, you should pursue the diagnosis. Red flags in aortic dissection. What do we say? Risk factors. We said hypertension, connective tissue disease, certain syndromes like Marfan syndrome and others. Presenting complaint associated symptoms itself, character of the pain, tearing, radiating to the back, associated symptoms like syncope, any neurological symptoms that increase the likelihood of having an aortic dissection. The exam finding itself. So what do you expect to see in aortic dissection? So pulse deficit, unequal blood pressure, right? What else? Murmurs, aortic regurg, murmur if it's extending. Image finding, we said the chest X-ray finding. 25 years old male, admitted under trauma team following MVA. Last night, complaining of chest pain, central associated with dyspnea. He looks ill, tachypnic, blood pressure and heart rate are okay, tachycardic a bit, tachypnic and desating. So how does he look? He looks ill. Okay, should I intervene? Yes, what can I do in the meantime? Oxygen is there, so you can give him oxygen and you can assess. There is still wide differential. ممكن تكون PE صح؟ طيب. So don't fixate on one diagnosis. Still there is the 6, we can consider them. So should I intervene now? We said we give him oxygen. What are life-threatening possibilities? The top is being tension pneumo. So you examine him, you give him high flow oxygen, assess him clinically. This is your exam finding. Decreased air entry in the left side, hyperresonance on the left side, tracheal deviation, there is JVB. What do you do next? Chest X-ray? ليش ما هو chest X-ray? So it's a clinical diagnosis. Don't be this guy, huh? Don't order the X-ray. So what do you do? Okay. 14 gauge needle, second or third intercostal space. Okay. Then ultimately you need the chest tube. Right? So tension pneumothorax. Consider it for right clinical context. It's a clinical diagnosis. Don't wait for the X-ray. Needle thoracostomy. Eventually you need to do the chest tube. If the same patient we talked about, the trauma patient, was having this X-ray finding, what do you consider? Tamponade. Okay. So what do you expect for tamponade to see clinically? ايش؟ Okay. Raised GFB. Hypotensive. Tachycardic. جميل. So لو سوينا لهم ECG, what can we see? Tachycardia, sorry, 1. So tachycardia, they call it electrical alternance, which is different QRS complex amplitude, صح؟ Due to انه في fluid, فالconductivity is there. The other thing is low voltage all over, so sinus tachycardia, electrical alternance, and low voltage all over. So cardiac tamponade. Consider it for clinical context. You don't need to do anything about it at that moment unless he arrests. So you call for help. Eventually he goes for pericardiocentesis if he is sick. So last case is a 55-year-old male admitted in the cardiology team as a case of new onset AFib for workup. He underwent T transesophageal echo today to assess whether there is a leafy thrombus or not. Chest pain, retrosternal, rotating to the back, both shoulder. There is odonophagia and fever. This is all progressive all over the day after he had the T. Exams, he looks ill, tachypnic, febrile, 38. So, does he look ill? Yes. Vitally, other than febrile and mildly tachypnic. Should I intervene? What do you do? Do chest X-ray? Other than that, غير X-ray. ECG a very cheap test you can order for any chest pain. You have to do an ECG, so it tells you a lot. Very cheap. Paper or ink. Right. So our top differential is esophageal perforation. He's a cardiac patient, so there is still possibility of having cardiac elements, صح? So ايش اللي خلانا نقول esophageal perforation؟ ده ايش؟ Yes, iatrogenic. So this is the X-ray. Forget about the arrow. ايش تشوفوا هنا؟ So there is pneumomediastinum. It could be normal again, but You should, once you consider the diagnosis, know your sensitivity and specificity of your imaging or your test. And again, it could be normal, but if you highly suspect it, you should pursue the diagnosis. So here it's a pneumomediastinum. You could have some pleural effusion on the right or on the left, certain cases. This is the ECG. Again, he's non-AFib, and this is his ECG AFib. So I'm considering esophageal perforation. Why do I need to worry about esophageal perforation? Mortality is very high, if not caught early. So esophageal perforation is a very critical diagnosis, needs to be ruled out. له term ثاني syndrome في certain population. ايش اسمه؟ Perhaps syndrome. Mallory's is different. هذول يجوا في ايش؟ Yeah, spontaneous twitching, vomiting في alcoholic patient. They have tear وبعدين they develop esophageal perforation symptoms. So remember, esophageal perforation, it's post-esophageal instrumentation. Even there is case reports with just an NGT placement. So anything that goes through the esophagus can cause esophageal perforation. NGT, endotracheal intubation by mistake, يعني حصل esophageal intubation, endoscopy, TEE, all of these can cause esophageal perforation. The most common cause of esophageal perforation is etiologic causes. Mortality is very high if delayed diagnosis, so you keep him in PO, aggressive resuscitation with fluid, broad-spectrum antibiotic, early surgical consult. Remember, this is my take-home messages. Remember the 6 diagnoses talked about. We said ACS, pulmonary embolism, aortic dissection, tamponade, ماني قاعد اسمع. Okay? And esophageal perforation. Right. Considering them and recognizing them is the most critical step. If you don't think about them, you're going to miss them. You know them, but consciously, if you don't think about them, you're going to miss them. So don't fixate on one diagnosis. Consider the other diagnoses. There is still a chance that this patient can have that diagnosis if it's highly suspected to have one diagnosis. When in doubt, call for help. جميل. They go in septic shock because whatever goes through the esophageal goes through the lungs, mediastinum. They develop mediastinitis, then septic shock, and this, you need to go and surgically drain these tissues. Right? If you give antibiotic, it's not there. So they keep them in PO. There is a school of conservative treatment, non-surgical, but it has to be monitored early when they see the response, how patient progress over the next few hours, days. Threshold of going surgical is very low for these patients. Mortality is as high as 80%. So it's a critical diagnosis you should need to consider.